Young investigators in kidney disease are definitely a hope for the future.
The young investigator often has a new approach.
Don Seldin was a master teacher and clinician.
He had tremendous impact on young investigators.
One of the major advantages to the whole community of the Young Investigator Award is to highlight new areas of science.
We believe that funding young investigators is the key to keeping the next generation of scientists bringing new treatments for both kidney disease and heart disease.
Dr. Seldin always encouraged young investigators to go after it with dedication and diligence. Give it everything you've got. He was a leader in academic nephrology, not only in research, but also in the practice of nephrology and education.
The Department of Medicine at Southwestern took giant steps forward because of Dr. Seldin. He helped many young investigators by directing them to the most logical set of experiments that would dig into the problem they were studying.
He paid a lot of attention to young investigators because he realizes they are the future.
Young investigators are actually making new discoveries that will help everyone, not only in nephrology, but in all fields of research.
Research is at a really exciting time. We know more, we have more technology than we ever had before. So the potential to impact human disease is great.
I think it's appropriate for Dr. Seldin's name to be wedded to the Young Investigator Award. It bonds his name to those individuals who will carry science forward into a new era.
The 2024 Donald W. Seldin Young Investigator Award, co-sponsored by the American Society of Nephrology and the American Heart Association's Council on the Kidney and Cardiovascular Disease, is presented to Professor Hiddo Heerspink for his productive and creative contributions in kidney-related research and teaching. He is a professor in the Department of Clinical Pharmacy and Pharmacology at the University Medical Center Groningen in the Netherlands. He is also a co-joint professor at the University of New South Wales in Sydney. Professor Heerspink studied pharmaceutical science at the University of Groningen and earned his PhD from the University Medical Center Groningen. After training at the George Institute in Sydney in 2008, he learned that his first publication was accepted in The Lancet. In 2012, he was appointed to UMCG's faculty and advanced through the ranks to full professor within 5 years. The primary focus of Professor Heerspink's research is optimizing current treatment strategies and finding new therapeutic approaches to halt the progression of kidney and cardiovascular diseases in patients with diabetes, with a specific focus on personalized medicine. He has led many clinical trials with novel interventions to reduce diabetes-related kidney and cardiovascular complications, and has collaborated with leading investigators from around the world. His innovations in trial design and statistical analysis have informed and enhanced clinical practice. Professor Heerspink's work has expanded into cardiovascular and metabolic disease, in keeping with the AHA's recently launched CKM Health Initiative. Among his most notable contributions are his participation in the CKD Prognosis Consortium, his role in highlighting the importance of albuminuria in CKD progression, his development of novel disease detection methods, and his leadership of some of the most influential clinical trials in nephrology. Professor Heerspink has authored or co-authored more than 500 peer-reviewed publications, and is an editorial board member of Diabetes, Obesity, and Metabolism, and CJASN. He has served on several international conference committees, including the European Association for the Study of Diabetes, and has given more than 200 invited lectures. Through his teaching, mentorship, and supervision of PhD students and postdoctoral fellows, he has increased the pool of scientists engaged in kidney-related research across the globe. The recipient of several distinguished awards from the EASD, Harvard, and the Japan Diabetes Society, among others, Professor Hiddo Lambers Heerspink has established himself as one of the leading clinical scientists and educators in nephrology.
in welcoming this year's Young Investigator Award, Dr. Hiddo Heerspink, who will present on innovations in clinical trial design and conduct for new therapeutic approaches in CKD.
Wow, good morning, ladies and gentlemen. What a great morning for me. And I'd like to thank the ASN, the American Heart Association, the Kidney Week organizers for giving me the opportunity to deliver the Donald Seldin Award lecture this morning. I'm deeply honored to receive this award. And it is my pleasure to deliver this talk about new innovations in clinical trial design and conduct in order to advance the discovery of new treatments for patients with chronic kidney disease. My disclosures are listed on this slide. Because indeed we have made great progress in the last couple of years with the discovery of new treatments for patients with CKD. It started 5 years ago with the SGLT2 inhibitor canagliflozin, as shown here on the top left. The Kaplan-Meier curve demonstrated that for the first time an SGLT2 inhibitor on top of ACE inhibitors and angiotensin receptor blockers can reduce the risk of kidney disease progression. A year later, finerenone, a non-steroidal mineralocorticoid receptor antagonist, demonstrated kidney and cardio protection. And then endothelin receptor antagonists can also reduce the risk of kidney outcomes and slow the progression of kidney function decline in patients with IgA nephropathy. And most recently, the FLOW trial demonstrated that the GLP-1 receptor agonist semaglutide reduced risk of kidney failure and cardiovascular endpoints in patients with diabetic kidney disease. So we have 4 new drug classes that can protect the kidney. And now you could argue that we have solved the problem of chronic kidney disease, we have cured chronic kidney disease. Well, I don't think that's completely true. I still believe that there is residual risk and that we have to innovate our trials, innovate the therapies to further reduce CKD progression. And I will explain this with an example from the DAPA-CKD trial, the trial with dapagliflozin in patients with chronic kidney disease. The trial demonstrated that dapagliflozin reduced the risk of kidney failure by 39% and reduced albuminuria by about 30%, as you can see in the graph on the left. On the right here, you can see the distribution of baseline albuminuria values in the 2,000 patients that were treated with dapagliflozin, the solid blue bars. And then when you look after 4 months of treatment with dapagliflozin, you can see that there are more patients in the lowest albuminuria category. So the distribution has shifted to the left. But what you can also see is that there are still more than 650 patients while being treated with dapagliflozin that still have an albuminuria level of more than 1,000 milligrams per gram creatinine. And these patients, despite being treated with dapagliflozin, are still at risk of CKD progression. And that's illustrated here in this graph. If we look at the distribution and we take those patients with an albuminuria of 1,000 milligrams per gram, you can see that the risk of those patients is identical to the patients that were treated with placebo. So while you are receiving the treatment, if you have still high albuminuria, you are still at a similar risk as a placebo-treated patient. The only difference was that the dapagliflozin-treated patients came from a higher level. They came from a level of 1,500 milligrams per gram. The albuminuria was reduced to 1,000 milligrams per gram. But at that level, the risk was the same as the placebo-treated patients. So this suggests that we have to further reduce albuminuria in order to further reduce the risk of kidney disease progression or cardiovascular disease. So we have to think about how can we then optimize all these new drugs, and should we think about combination treatments? And then if we think about combination treatments, which combination for which patient? A couple of years ago, we already started to think about this. And we did a study in patients with chronic kidney disease that were treated with dapagliflozin or the MRA eplerenone. When we started the study, finerenone was not available, so we had to choose another MRA, and we chose the eplerenone. This was a crossover study. And as you can see here, dapagliflozin reduced albuminuria by about 19% on the left. And then if you stop dapagliflozin, you can see that in the washout period, the albuminuria levels return to baseline. Eplerenone reduced albuminuria by 34%. And then if you stop the drug, the albuminuria levels return to baseline. 19 plus 34 is 53%. And indeed, the combination reduced albuminuria by 53%, an additive effect of the two drugs together. If you stop the drug, the albuminuria levels return to baseline. We know that SGLT2 inhibitors reduce the risk of hyperkalemia. And interestingly, in this study, we found indeed that eplerenone, as expected, increased the risk of hyperkalemia. There were more patients with hyperkalemia. But if you look at the combination, you see fewer patients with hyperkalemia. And a similar signal is seen for potassium levels. There is indeed more patients with potassium levels greater than 5, but fewer in the combination. So here we have a combination treatment that has additive effects in terms of efficacy and less side effects. A similar pattern is seen with another combination. This is a study that we presented last year here at Kidney Week. In this study, we combined an endothelin receptor antagonist, zibotentan, together with an SGLT2 inhibitor, dapagliflozin. And the combination indeed reduced albuminuria by about 60%, and that was significantly more than dapagliflozin alone. So with this combination, you get more efficacy. We know that SGLT2 inhibitors have diuretic effects. And on the other hand, we know that endothelin receptor antagonists can cause fluid retention, which can lead to edema and possibly even heart failure. So can we now combine an endothelin receptor antagonist together with an SGLT2 inhibitor to mitigate and attenuate the risk of fluid retention? Well, indeed, that seems to be true from this study, because in this study we measured total body water, extracellular volume with bioimpedance spectroscopy, and with the low-dose zibotentan in combination with dapagliflozin, the blue line, you see hardly any fluid retention anymore. So maybe in the future we should combine an endothelin receptor antagonist with an SGLT2 inhibitor to enhance the protection and mitigate the side effect of an endothelin receptor antagonist. But as I said, which combination should we use for which patient? This was a study that we conducted in 63 patients with type 1 or type 2 diabetes. And this again was a rotation study. So every patient was treated with telmisartan, empagliflozin, and then linagliptin, the DPP-4 inhibitor, and then baricitinib, the JAK-STAT anti-inflammatory drug. And it seems that every patient has a preferred drug. 33 patients responded in terms of albuminuria reduction to telmisartan, but they did not respond to any of the other 3 drugs. There were patients who responded to empagliflozin, but they did not respond to the other drugs and modestly to telmisartan. And the same was true for linagliptin or baricitinib. So maybe we have to tailor the medication or the combination of treatments to the right patient. But to do that, we have to innovate our clinical trial designs. And we have to find new study designs to tailor those medications and individualize the treatments. But we also need new biomarkers to identify people at risk of progression for our future trials. We have to use new digital tools to conduct clinical trials at home. We have to think about decentralized clinical trials. And we have to think about new methods and endpoints to assess long-term drug effects. And I would like to touch upon these 4 elements in the next couple of minutes. There are various types of study designs that you can use to study personalized medicine. The NS1 trial is one type of a design where individual patients are treated multiple times with the drug and placebo, and I will give you an example of such a study design. We can also use biomarker stratified designs, where we first identify patients based on a biomarker profile. And then the positive biomarker patients are randomized to active medication or placebo, and the negative biomarker patients are randomized to active medication or a control. And then we assess the treatment effect in the biomarker positive and negative subgroups. But we have other more recent trial designs that we can use as well. Basket and umbrella trials. A basket trial is an infrastructure to test multiple diseases with a single agent. And we do such a basket trial already in nephrology. This is the affinity basket. It's a basket trial where we test one drug, in this case an endothelin receptor antagonist, atrasentan, in patients with diabetic kidney disease, IgA nephropathy, FSGS, or Alport syndrome. So different types of kidney disease receive the same medication. But there are also umbrella trials, which gives you an infrastructure to test the same disease, but participants with different molecular phenotypes are treated with different interventions. And the Neptune Match umbrella trial is one example in nephrology. A single disease, these are FSGS patients, are then molecularly phenotyped and based on their phenotype receive different interventions. And then finally, we can think about platform trials. These are multiple interventions, including this platform trial allows assessment of multiple interventions, including interactions between individual interventions or combination treatments in a single disease, like kidney disease. It provides a standing trial infrastructure with no fixed end date. A core protocol defines key design elements, and one can add new interventions while the core protocol is ongoing. It's an ineffective agents can be removed based on accumulating data during the conduct of a platform. We are conducting such a platform trial in nephrology already. And this is the Captivate platform. And the design of the Captivate platform will be published in the next few weeks in JAMA Network Open. It has a core protocol and different domain-specific appendices where we test different interventions. The first domain will test finerenone versus placebo on top of SGLT2 inhibition and ACE inhibitors and angiotensin receptor blockers. The second and third domain are currently in the startup phase. And the beauty is that you can now assess patients who participate in the first domain can also participate in the second or third domain, which allows you to test interactions between different interventions that are tested in these different domains. Now, what about new biomarkers and biomarker panels? I believe that we should also use them in our future clinical trials. In our current trials, we always enrich the population based on high albuminuria. And the reason is that these patients are at higher risk of progression towards the endpoint, a late manifestation of kidney disease, namely dialysis or kidney transplantation. And this example from the CANVAS trial, which tested the effect of canagliflozin, shows indeed that those patients with high albuminuria have the highest kidney event rate. But if we look at the total number of events, actually the patients with normal or microalbuminuria show a similar number of events. So the question is, can we identify these patients, these 89 patients with normal albuminuria, with new biomarkers in order to enroll them in our future clinical trials? A machine learning model has been developed which includes routinely collected laboratory data, including urea, hemoglobin, blood cell counts. And that is a new model that predicts disease progression. If we compare this ClinRisk model with eGFR and albuminuria, you can see that the predictive performance, the area under the ROC curve, is higher compared to our standard biomarkers to enrich clinical trials. Now, if we apply that to the CANVAS trial, we see here on the right that indeed those patients with high albuminuria in the A3A category have a higher event rate and more patients reach the endpoint compared to normal albuminuria. But as soon as we also use the ClinRisk score, we can see that the patients with normal albuminuria and a high ClinRisk score have a similar event rate compared to the patients with a high albuminuria. So maybe we can use this tool in our future trials to identify the patients with a high risk of CKD progression. We can also use new digital tools to conduct studies at home. And this is an example of an at-home trial. In this clinical trial, patients never visited the hospital. They collected all the data at home. They used blood pressure and body weight devices that was connected to their mobile phone, and the data was directly transported into a cloud-based data system. They collected almost every day blood and urine samples, which were sent by regular mail to a laboratory where the samples were analyzed and stored in the cloud. The investigators then analyzed the data and they reported the data. This was an NS1 trial, so patients were exposed 2 times to dapagliflozin, and these were patients with type 2 diabetes and microalbuminuria, and they were exposed twice to placebo treatment. Dapagliflozin, first and second exposure, reduced albuminuria. And you can see here the individual patient responses. It's quite consistent in the dapagliflozin group when you measure the first and the second time, but you can see here in the placebo group there's more variation during the first and second exposure when you look at individual patients. And indeed, when we correlate the first response to albuminuria with the second response to dapagliflozin, there is a nice correlation. So the patients who responded well the first time responded well the second time. You don't see such a correlation in the placebo group. And of course, this correlation is not perfect because we know that there is random fluctuation in albuminuria from day to day. There is measurement error. But despite that variation, we found this nice correlation, which suggests that we can monitor the treatment response at home. We also asked the patients how they experienced the at-home data collection. And if you look here at this 5-point Likert scale, you see that patients found it easy to collect urine at home and ship it to a laboratory. The patients also experienced no problems with connection of their mobile device to their mobile phone. Now in this next study, we try to optimize the treatment. Again, decentralized at home. So in this study, we test now 2 drugs, an SGLT2 inhibitor, and then on top of that, finerenone. And we stratify and we make decisions based on the response to empagliflozin. So if a patient responds well to empagliflozin, but the residual albuminuria is too high, more than 30 milligrams per gram, we're going to add finerenone. If the patient does not respond to empagliflozin, so an increase in albuminuria, we switch the medication to finerenone. And these are the first patients that participate in this study. The first patient here showed a 20% reduction in albuminuria, the second 40%, and the third did not show a reduction in albuminuria. You can see here on the right the patients and the residual albuminuria, all above 30 milligrams per gram. So in these first 2 patients, we're going to add finerenone, and in this third patient, we switch the patient to finerenone. And this is the result. In the first patient, actually finerenone did not reduce albuminuria. In the second patient, indeed, when we monitor this at home, the patient responded and the albuminuria further reduced. And in the third patient in whom we switched the patient, you see now a modest reduction in albuminuria, but still too high, above 30 milligram per gram. We're going to continue this study, but this is an example how we can monitor the treatment response at home and how we can optimize medication for individual patients at home. And then finally, we can also think about new methods and endpoints to assess long-term drug effects in our future clinical trials. If we look at the big clinical trials that we have conducted in nephrology, more than thousands of patients participate in these clinical trials. Only about 10% during the duration of the trial reached the established clinical kidney endpoint of a doubling of creatinine, halving of kidney function, or end-stage kidney disease. These endpoints are composite endpoints, and we always look at the time to the first endpoint, which is often a decline in GFR. But the clinical relevant endpoint is dialysis or kidney transplantation. But in our clinical trials, we only look at the time to the first event, the time to GFR decline. In addition, many patients do not experience an endpoint. And in these clinical trials, the hazard ratio is determined by the number of patients who reach the endpoint. These are often the fast progressors in the trial, a selection of the patient. But ideally, we would like to assess the treatment effect in the overall population, in all patients. New developments in endpoints, mainly from the cardiology field, can now allow us to involve the data from all patients in the endpoint. Hierarchical composite endpoints analyzed with the win odds or win ratio approach allow us to prioritize the most relevant endpoint and then also use GFR slope in the endpoint for patients who do not experience a clinical endpoint. So how does that work? In contrast to taking the time to the first endpoint, we are going to prioritize the most relevant endpoint, in our case, dialysis. And we make pair of patients, an active patient and a control patient. And every time we compare the active with the control patient, and we compare if the patient reached dialysis. If the control patient reached dialysis, the treated patient is the winner. Vice versa, if the treated patient reached dialysis, the placebo-treated patient is the winner. If none of these patients, if both do not reach the dialysis endpoint, we move down one step in our hierarchy and compare end-stage kidney disease, a GFR below 15. And again, we're going to compare if the patient, active or control patient, reached this endpoint. So we get many comparisons because all active patients are compared with all placebo-treated patients. And then we have a set of winners in the placebo group, a set of winners in the active group, and we calculate the ratio, which is the win ratio or the win odds, the likelihood of being a winner compared to placebo. If we do that in all our big trials, you can see here on the left the original endpoint and the hazard ratio. And on the right, you see this win ratio or win odds, the likelihood of being a winner when you are assigned to active medication. And indeed, if the hazard ratio is reduced, you can see that the win odds is increased. So the direction and the magnitude of the effect is consistent. And now we can use this new method, the hierarchical composite endpoints, to our future trials. Where is this particularly relevant? For example, in trials where we do not see a lot of events, like in patients with FSGS. This is an example from the DAPA-CKD trial. There were few patients with FSGS participating in the trial. There was a tendency that the drug worked, a hazard ratio of 0.45, but the confidence interval crossed 1 because there were not so many endpoints. This eGFR slope also favored dapagliflozin in these patients, but because we did not have so many patients, the effect was not statistically significant. But now, with this new endpoint, we can combine the clinical events with the GFR slope. And if we do that, and if we calculate the win odds, when we use this approach, you can see the win odds is 1.7, statistically significant. Why do we find this statistical significant effect? Because this new endpoint provides us more statistical power to detect treatment effects. And you can see that here in this graph. For 225 patients, the statistical power for this new endpoint is higher compared to the composite traditional endpoint or to GFR slope. So a new innovation that we can use in our future trials. So my take-home message in this Donald Seldin lecture is that despite multiple new proven effective and safe therapies, the risk of kidney and cardiovascular disease remains high. Drug combinations are needed to further optimize pharmacotherapy and prognosis for patients with chronic kidney disease. These drug combinations have to be tailored to each patient, taking into account the heterogeneous molecular phenotypes. Prospectively tested in randomized controlled clinical trials like the NS1, basket, umbrella or platform trials. And these trials can be done now at home using endpoints that prioritize clinical events and enable studies in smaller targeted populations. Decentralized at-home clinical trials conduct has great promise, in my view, for the future. Now, on that note, I would like to acknowledge and thank the American Society of Nephrology, the American Heart Association, to award me with the ASN-HA Donald Seldin Award. I am extremely honored and privileged to be the 2024 recipient. And I want to express my gratitude to the award selection committee, the Kidney Week organizers, and the ASN and the AHA. I believe that the recognition and the award I receive reflects the hard work and commitment of many people I have had the pleasure to collaborate with. Some of them are mentioned here on this slide, but for sure there are many, many others who have contributed to the work that I'm doing. I am incredibly lucky to have so many colleagues and friends with whom I collaborate and who support me in the clinical trials that I am doing. Without their support, I would never have been able to achieve what we have achieved in the last couple of years. In fact, in a more and more individualized world, where people often oppose each other, we scientists can show the value of collaboration because as a team we can achieve so much more than individuals. There are a few people I would like to mention in particular. First of all, my mentor, Dick de Zeeuw. Dick introduced me into nephrology. He convinced me and encouraged me to conduct clinical research, and he guided me and supported me throughout my career. The second person I would like to acknowledge is Vlado Perkovic. Unfortunately, Vlado Perkovic cannot be here, but Vlado showed me and taught me how to conduct and design clinical trials. He showed me the value of involving many other people in research projects. And he gave me the opportunity to visit and to live in a country I would really like to live in. And finally, Glenn Chertow. Glenn, you are in the audience. You are the most talented, polite, and dedicated nephrologist I have ever met and probably will ever meet. You never think about yourself. You always put yourself in second position and give others the opportunity to grow. Be it your patients, be it your colleagues, be it your fellows or trainees. And I would really like to thank you for that. And then finally, as a young investigator, I have a message to other young investigators. Please be involved in research, because as Donald Seldin already said here in this quote that he expressed at the American Society of Clinical Investigation, if investigations is progressively separated from clinical work and teaching, the educational process deteriorates. Only the investigator can teach the methods of critical inquiry acquired in research into the routine practice of medicine. I thank you for your attention.